entitled Targeted Therapy of Endometrial Cancer, the Cinderella Story.
Can you put my slides? Good. Thank you very much. It's an honor to be here. It's my first time in Egypt. So unfortunately only 2 days, and I'm flying back on Saturday. So I have to come back and see the pyramids and the museum and everything, and see the old culture, which is important. So this talk is targeted therapy in endometrial cancer. I called it the Cinderella story because we have really changed everything, how we are going to change, and the management of endometrial cancer. And I would say we are privileged to be part of it, that this is happening. These are my declaration of interest. So going to the past, I'm saying going to the past. It's what we were doing is one chemotherapy versus other, doublet versus doublet, doublet versus triplet. At the end, we went back from triplet, GOG-209, to doublet, carboplatin paclitaxel, and that became the first line therapy for the patients who are stage 3 and 4 or first relapse. And that's where we ended up with, that's the top we got, and this is what we have. So I think this slide is very important. That's GOG-209. That shows us that even we have the best treatment at the moment available, this is what you get. This is not ovarian cancer where you get a better result. In endometrial cancer, you can see how the Kaplan-Meier curves are falling down, coming to a plateau, to a much lower level. And once patient has progressed on carboplatin paclitaxel, and then you don't have much available, what we do is try to treat them as ovarian cancer with single agent chemotherapy. But look at the response rates and look at the median PFS. It's quite pathetic. I would say more or less, you can say whichever treatment, whichever monotherapy you take, you would have about 3 to 4 months of median PFS. The best, what we use is weekly paclitaxel or doxorubicin, but this is what we have. So I think that is where we were stuck with and the same is the case for endocrine therapy. We did a trial, a paleo study, where we showed that letrozole alone had a median PFS of 3.5 months. That's a randomized trial. So this is where we were after relapse of carboplatin paclitaxel. I think the biggest change we saw was in when we saw the results of the Cancer Genome Atlas, the TCGA data, which changed the way we think. So it's not just two type of disease, endometrioid and non-endometrioid. It's a very heterogeneous disease, and that is important because this heterogeneity gives us a possibility. There are so many druggable targets which we can pick up and treat the patients accordingly. That gives us opportunity to improve the outcome of our patients. I think I will just stand for a short while. Poly, for example, I believe it's even less than 7%. In TCGA it was 7%. We have seen the new trials coming in, it's down to 3%. But these patients, I would say, never die. They don't need any treatment. We are dropping the treatment for stage 1 and 2, but we have to do trials in stage 3 and 4 as well. If they need any treatment, they are so good because they're so ultra mutated. They cannot just divide. They die themselves. Then you have a group of patients, about 1/4 of them, which are MSI high, mismatch repair deficient. This is an extremely sensitive tumor to immune checkpoint inhibitors, and you will see in a moment what I'm talking about. And remember, when I talk about it, I showed you the response rates of monochemotherapy were in the range of 10% and how we have moved to it. And then you have all others, copy number high, and then the copy number low. I call this copy number low as a Jurassic Park with different mutations. And let's come to that. I think this slide try to summarize all the molecular abnormalities where we have some sort of drugs. I call them druggable targets. So we can pick, now we don't have to do the dinosaur trials, drug A given to all patients or drug B, no. We pick up according to the molecular profiling, try to do the trial in that, and I'll show you what we are doing. We are in the middle of changing the history, and we will definitely have within the years a lot of new treatments and much better management for these patients. You can see up there endometrioid, serous, and carcinosarcomas, and here is the classification and how the mutational burden falls, how the grade of tumor in endometrioid, estrogen receptority, and the p53 mutation, another important target we are working at, and so on and so on. So if we go by this classification and look at, let's say, estrogen receptors, and we did a trial because I said letrozole alone has a median PFS of about 3 months. And we did a small randomized phase 2 trial. It was a placebo-controlled trial which showed that there is which indicated that probably there is a good chance to add a CDK4/6 inhibitor and to endocrine therapy in these tumors and get a better result. And then comes another issue, and that's not the scientific issue, that is the issue to discuss with pharma. So I begged the pharma who has palbociclib, please give me a possibility to do a phase 3 trial so we can get it approved, the doublet. What was the answer? Endometrial cancer is not our area of interest anymore. Done. They are in breast cancer, they're making money, so they don't need to work in. So this is how it works. And we had to work hard with all the small and big pharma to see if we can get a CDK4/6 inhibitor. And now we are starting a trial, NGOTN17, with a smaller pharma who has agreed to that we can do the phase 3 trial on the data what I have shown. So it's not that easy to move in such a disease small disease where companies are not interested in making money. They don't make money on that. Another target is HER2. And if you look at the Amanda Fader's trial, it was only 50 patients, but it gave a clear indication that adding to carboplatin paclitaxel trastuzumab has some benefit. But that's a phase 2, very small trial. It would put in the NCCN guidelines, then you can get reimbursement in US, but not in Europe. You have to do phase 3 trial, and I'm working very hard with, especially now with Daiichi Sankyo, who has TDXD. You saw the data on TDXD. So probably we will bring TDXD into endometrial cancer, and I'm sure that we would be able to help a number of patients. It's not just that small HER2 group, and one should want to add the HER2 low. So we will have a broader, about 30% of the population to do this trial. So you will see that trial coming hopefully this year, by end of this year. Then the P10 mutation, we saw that's a difficult one. mTOR inhibitors are toxic. We saw Amitoza performing this trial and showed PFS benefit, but we still learning curve how to integrate mTOR inhibitors and drugs like that into clinics so we can get a better efficacy of that. Another trial which was performed also of phase 2 by Brian Slomovich, again indicating we should go further, but we have to learn how we are going to use these drugs. We have not moved yet with these drugs. PIK3CA, you can see that's quite a big population. I think it's half of the population which is PIK3CA positive. And we proposed a trial, and we had signed agreement that we will get grant and the drug from, I don't want to name the companies, but you can just guess, Alpelisib. And everything was done, and we were submitting in the UTRACT to the agency for approval, and we got the approval We got the ethics approval in 7 countries in Europe, and Nordic Society was sponsor. And at last ESMO, they came to us and told that now they have merged their oncology department to the rest, and they had to choose the area of interest. And we are sorry that endometrial cancer is not our area of interest anymore. So they withdrew their support. So we had to drop that, and I'm stubborn enough to try to find another company who can give me big 3 here to do this trial. Everything is ready, and we just need to have the drug and the grant. That's the problem with endometrial cancer. It's not ovarian. It's small patients. Companies are just not interested to put money on that, right? This is another very interesting story. The p53 wild type. This is not p53 abnormal. This is p53 wild type. There is there's a drug first in class called selinexor, selective inhibitor of nuclear export. What it does is that normally in the cells you have good genes. Let's say p53 wild type is one of them. These genes go out of the nucleus to cytoplasm and come back. So the cancer cells are very smart. They don't let them come back to the nucleus. And if they are not in nucleus, they cannot be the anti-cancer genes anymore. This selinexor does is that they inhibit the transport from the nucleus to cytoplasm with exploitin being blocked. And that means that p53 wild type, the good gene, stays in the nucleus and work. And when we saw that these results of the Ciendo trial, which Ignace Vergode presented last year, we saw in the whole population there was not statistically significant effect. But when we looked at the subgroup of p53 wild type, the biology fits very well to what we saw in the clinic. And that brings us that now there will be a phase 3 trial running only in p53 wild type population with this drug. And there is another drug which inhibits somewhere the same way, but in a little bit different session, MDM2 inhibitor. And that trial will also start. So there are 2 phase 2 trials aiming at p53 wild type tumors in endometrial cancer. So can you imagine that we are changing everything, the way we treat our patients? Let's go, and this is this is not future, this is now. That's the immune checkpoint inhibitors. So let's go first look at the so-called hot tumors, which are microsatellite unstable or mismatch repair deficient. The first trial we saw, the results of first trial we saw was Keynote 158, which was a non-randomized. Remember, EMA is very conservative. They do not give approval to any non-randomized trials. It's very difficult. But in this case, because it's such an unmet need, we got approvals for the drugs with non-randomized trial. You can see the Keynote 158 with pembrolizumab in these patients, and look at the waterfall plots. There are not many patients where tumor is progressing. Most of these patients' tumor is shrinking, and that's why EMA has given approval to use pembrolizumab in biomarker positive population, that is either MSI high or mismatch repair deficient tumors, which is really great. Another trial, which is actually another non-randomized trial, which is much larger trial, about 150 patients in this biomarker positive population, is the Garnet study, which used dostarlimab. And both of these trials, I forgot to say on the 158, as the response rates are about 40 to 50%. If you remember, I told you the response rates of monochemotherapy are at about 10%. So that's the difference which made it possible that we got approval to use single-agent dostarlimab or single-agent pembrolizumab for the patients who are mismatch repair deficient. So that's another very important possibility for the patient. But remember, these approvals are in the relapse second post-carboplatin paclitaxel. Why we have to wait? And I'll come back to that. That's why we do not have to wait for that. Let's take the whole population, the mismatch repair deficient and mismatch repair proficient disease, the whole. We know that single agent immune therapy works not very well in the mismatch repair proficient, the MSS. The response rates are about 10 to 15%, the same as chemotherapy. So something has to be done, and one was to combine the immune checkpoint inhibitors with the small molecules VEGF, which is in this case, in the keynote, it was lenvatinib, the small molecule. So combination of lenvatinib pembrolizumab, first Wikimarker did a trial on 100 patients, non-randomized, and then we have the 775 trial, keynote 775, and look at the results. I think there are a lot of things we can learn from here. First of all, look at the curves. These are not, which we are used to in earlier days with chemotherapy, these are not banana curves that they separate and then fall into each other. These curves separate and keep the separation. That means probably there is a population we are curing. A small number, but probably there is a plateau and they will never progress. That's one thing. Second thing, look at the chemotherapy. As I said, the median PFS of chemotherapy is 3.5 months. Whichever you choose, here you have weekly paclitaxel or doxorubicin, a choice. There are two things. The third thing is, whichever endpoint you take in 775, it's the PFS in the MSS population or intention to treat population. If it is the OS, if it is the quality of life, everything is positive. So this is first trial in so many years in endometrial cancer, which has given us a survival benefit. It's a tough combination. It's difficult. I don't know how in your population, what we have to do is we have to make sure that our staff, our young doctors are completely trained to manage the toxicity. We spend a lot of time with the patient and their relatives before we start the treatment to teach them so they don't just sit home and do not report us, and we try to be proactive. So in this way, we can start the treatment. Why we still want to do that, though there are toxicities, because we know, I have seen the tumor shrinking in no time. So this is very positive, and that's why it keeps us giving this combination to the treatment. So what is the future? The future is here. These all trials are first line. So these are the trials in primary stage 3, 4 or first relapse or even earlier. And I have put 3 colors there because there are 3 ideas being tested. These are all phase 3 trials. So the first one, the red ones, are the trials where carboplatin paclitaxel is the backbone and we are adding immune checkpoint inhibitors on top of that. So it's plus minus immune therapy add-on, right? And the first trial will be reported is the N-GOT-N6 Ruby trial in March. So keep tuned. There was a press release that it's a positive trial. Yes, it is. And it will be presented both in ESMO Virtual Plenary and SGO on the same date, on the same day. So be there in March, in end of March. And we are going to change the history once again. The second, the blue one, is the same chemotherapy backbone and adding immune checkpoint inhibitors in whole population. And after chemotherapy, adding PARP inhibitors, because we have seen, especially in the patients who are more like serous or p53 mute, their PARP inhibitors will have a higher efficacy. So let's see how the results will read out. Probably the DUO-E trial will have a readout by end of this year. So it would be interesting. So the green ones, I think are the most exciting ones. Why? We are completely replacing chemotherapy. We are asking the question, do we need chemotherapy in first line? Can we save chemotherapy at relapse? So the LEAP-1 trial is the same as 775, but upfront. It's not comparing to single agent chemotherapy, it's comparing to carboplatin paclitaxel, which is the standard of care. So it's carboplatin paclitaxel versus pembrolizumab. You have to be at ASCO, because I understand that the results will be presented at ASCO in it. And the last 2 trials which are here, I think biologically designed, the best trials I love, because this is only in the population, I call them hot tumors, the patients who are mismatch repair deficient. These patients, first line, you compare carboplatin paclitaxel versus single agent immune checkpoint inhibitor in the EN15 pembrolizumab, in Dominica dostarlimab. So these two trials, if positive, we would have a possibility for this 1/4 of the population not giving chemotherapy, giving immune therapy alone. Immune therapy alone, I'm sorry, I'm oncologist biased, is, for me, it's a piece of cake. It's the toxicity wise, it's so easy to give. But when, of course, when you add other drugs, it gets toxic. So I feel this would be a great opportunity. So my second last slide is the one which you will see in March. We will be presenting data on this trial, EN6. So this is the trial in stage 3 and 4 or first relapse, where standard of care is carboplatin paclitaxel, and that is randomized to receive dostarlimab or placebo, concomitant and maintenance up to 3 years. There are multiple, 3 primary endpoints. One is the mismatch repair deficient population, then intention to treat population, and third is overall survival. And I can say, because this is press release is there, all are positive. Okay, so this is the first one, but you will see that you saw all these trials. The results will be showing up in 23, 24. It's an amazing time we have. So if you take the key takeaways here, first of all, I would plead, please do molecular classification on your patients. It's not just endometrioid and non-endometrioid. That's the most important. Molecular profiling must be considered for treatment decisions. Targeting different pathways offers a promising strategy to enhance anti-tumor activity. And immune therapy is emerging as a new major treatment modality for our patients. And this is just the beginning. Thank you very much.
Thank you very much, Mansoor, for this